facilitate our job. So this is the distal margin of the second molar. This is the recipient side from our free gingival graft. After collecting the free gingival graft, I'm using angulated blade here because really the palate was super flat. I thought the angulation for the 15C was not good enough. And now I'm going to protect here. In that time, I used to apply the flow composite over the sutures, and I did not build up the shoot before. Sometimes you have too much blood. This was a little bit messy work, and I prefer to do the shoot before, right? But it still work and use that for a few years. And to suture here, same structure. Bifurcation here, get the loop over there, and start to fit the grafting position. One thing is, does not matter which suture I'm going to need to use, but absolutely there is no movement or gap in between. Gap in between interfered in the survivor of the free gingival graft. Sometimes you lose part of the free gingival graft. So single interrupt sutures, compressive sutures is going to be used to adapt completely the graft here, okay? The direction of the mandible was in this direction, okay? This premolar was more lingual, so I do not graft in the wrong place, okay? I raise the position of the tooth. And eventually that is going to heal, make it possible for them to place the implants. I received this from the maxillofacial surgeon that has done the previous surgery. It was not my surgery, I did the free gingival graft, and I sent back for the patient to position the graft over here, the implants over. I just received a follow-up picture with the implants over there. No clinical picture, unfortunately, but many of my cases I use the follow-up because I just do one part of the treatment. Not all dentists document, not all dentists send back the pictures for us. Okay, so far so good. Nice. I don't know if I answered any questions, but they asked me to show this case. Okay, good.
How about if on the top grafting board is the peak?
If the grafting
On top of the board, grafting board is skin. Sometimes it's graft from the with the skin and bone together.
Okay. No, I never get a case like that one. So, sometimes even the hair grows, right?
Yes.
Yes, yeah. I never get a case with that. And to be honest, these I don't receive frequently. It's rare for us to have a case like that. Fortunately, to treat the patient, right? Nice. So let's go back for the implant site. This is the case that it is my friend that is maxillofacial surgeon that do big reconstruction sent to me on this case. Every time he sends me a case to me, oh Jesus. But it's the same thing. Prepare, take all the mucosa, recipient side over there. And here I suture because there's so much mucosa, I suture the mucosa down. And once more, big free gingival graft. And to create the keratinized tissue over. Right. Nice. Not pretty, but eventually going to be fine, right? Let's go where I was. Here, aesthetically compromising implant, okay? So I have all the problems here, and for me, I have absolutely no clue which way to apply a technique to that. I was thinking that I could solve the way, but we are not sure which technique is going to really solve that. Nowadays we have the protocol. We know what works here, what does not work. So basically in 2014 now that the patient started to do the treatment, I was trying to graft this papilla, right? What is the problem of this papilla? Narrow space, all the surroundings of the crown, the blood vessels came from the PDL. So if I'm going to cut this papilla, detach it, I have a huge chance for this papilla not to survive. If I tunneling this detach, it's the same thing. So it's a risk area. And what you are trying to do here, I want to try to make this papilla that die alone to help a connective tissue to survive. How someone that die alone is going to help someone to survive? So impossible, right? I need to understand about the anatomy. I need to understand that really the PDL here make part of the blood vessels. If this space is narrow, and if I detach this tissue, I kill the blood vessels. So what we do in cases like this one, let me move back here. I need to make the papilla wider. If I have a big abutment, what to do with the big abutment? Reduce for a narrow abutment. And you already can measure that with a periapical. If you change from this abutment to a narrow abutment, how much is going to be this space? If the space is not enough, what you can do? Take out the abutment and slip the implant, cover screw. So you know the strategy and you not risk. A few years back, let's reduce the abutment. Then the papilla was still not wider. And you try a technique and you fail. So nowadays at least you have some small reference. Maybe the 3 millimeters that I'm giving to you guys in a few future, someone is going to do a research and check that for 3 millimeters and a half, you have 90% of survival. And 3 millimeters, 70. So go 3.5. Nobody is still sure how wide is the papilla, but I feel comfort to detach the papilla to the palatal side and having been good results when the papilla is wider than 3 millimeters. Okay? And in this moment here, if I try to graft this, I'm going to have a problem to make anything survive here. What I need to do for this case? Take the abutment out, slip the implant, cover a screw, close this the flap, or make the tissue to blood, suture, let a new tissue to be, and then I'm going to apply a technique to vertical rebuild that. Tabletop is one of this technique. 2 days ago we discussed about that. Today I'm going to present a few alternatives still that help with something else. 2012, I have no clue. I was trying to graft in the same day and then remove the abutment. Okay, nice. One thing being doing correctly here, because now we are not talking about small grafts anymore. You're not talking about 1.5, 1 millimeter in thickness. We are talking about a graft that is going to have 4, 5, 6 millimeters in thickness. This graft demands nourishment by both sides. This graft demands partial splitting. And fortunately, the thickness of a extracted site here is better than in the center. Here I can do partial preparation. Here I can do partial. Here is total. So this area I can do partial preparation, right? We're going to redesign that in a few minutes. So partial preparation, the facial aspect of the tooth, nice. Releasing the flap, not good releasing. Nice. Getting a tuber, the utilization of the tuber. And one thing here, I think nourishment from this point, facial is going to be very good. Flap is going to cover. But when I look at the top, I have titanium here, zero nourishment. These small papillas like that does not help. Probably this papilla is going to descamate and be loose in the sequence. So the nourishment in the center is very poor. So after arranging that, I check the case. Everything worked buccally, but not on the top. We create volume, we solve the recession, we solve the color, but the papillas are not there. For the papilla, I need to respect the blood vessels, we need to respect the anatomy, okay? And back then, I didn't know that, right? This was the moment for us to apply one of the vertical augmentation techniques, right? Tabletop is one of these techniques here, right? What else? And what I was trying to do, back 2013-14, I was trying to apply a very nice technique that is called roll flap. Have you heard about this? So row flap does not solve papillas, right? And I was still not realized about that. So I make the contour of the row, I make the depthalization. When I lift the row, I realize that if I fold the row here, I'm going to create for the patient a tubercle, a tumor, right? And then I panic, and not panic, but I say, oh, oh. You know, O can be in Portuguese, can be in English, can be in whatever language. O is, we have a problem, right? I didn't know what to do, so I tried to invent something. I cut the roll in two pieces, like two small papillas to superpose the anatomic papillas without the between here. You know that does not work, right? They are too thin to support or to nourish anything. Basically, what I did was a very bad re-entry, right? Almost compromising the surgery previously. So this is the result after a few days. This is the result after the healing and the final crown delivery for the patient. Not bad. For almost 10 years back, the patient was glad about the result, compared especially to the beginning. But nowadays, the patient, they came to really have the papillas over there, and they need to understand this. Okay, so let's go for some techniques that can solve this kind of problems. What do you think about this case here? Causal picture. Beautiful contouring, right? When I see papers and clinical cases and people do a lot of reconstruction, and they, at the end of the treatment, they just show the coronal picture, I know that something is wrong. Because facially, we understand many years ago how to make the things work. But in the top, no. This picture here is exactly from this case. So patient received bone grafting, soft tissue grafting, implant, they reopened the case. When they delivered the provisional for the patient, they realized that was not enough tissue here for treating this deficient site. So I received the patient exactly here. So I remove the crown, I take periapical here, occlusal picture. Is your case now? Can I try to tunnel or lift or graft this papilla, or they are too narrow? They are too narrow, right?
Yes.
So, and I have a chance to reduce the abutment. Okay, Ricardo, look in the x-rays, we can measure the distance maximum that I can make the abutment is linked. And in my view, this does not have 3 millimeters. Okay? If you don't have 3 millimeters, make the maximum reduce of this abutment. What I can do with this case? I'm going to take out the crown, is lift the implant, let the tissue to the back, and then do a vertical graft. Okay? A lot of people, when do this, they remove the abutment, they use the cover screw, and they let the tissue to be created alone here. I don't like it, because take a few days for the tissue to close. Sometimes the cover screw has some bacteria in the early days until to close. When you reopen the case, we have some invagination of the epithelium inside. I prefer to get a high speed revitalization, let the blood flow, a single suture here or cross suture, sometimes with a collagen sponge, and the tissue is going to be faster to close, going to get better tissue over there. After 4 to 6 weeks, I can do the case again. So this is the case. After 5 weeks later, already closed that, and I need to deal with recessions, and I need to deal with the vertical area, right? So let's show this case step by step for you guys, and but basically there is a few different things here to upload in this case, right? I learned a lot to look my own cases. Every time I present the case, I know something that I did good, something that I did wrong, and this way we can evolve together, right? First thing, I'm going to have a vertical grafting here, like a tabletop. incision goes in the center, partial preparation. Everybody knows this, right? And here I have small recessions. So small recessions, I need to advance the flap. I can take the same opportunity that I'm going to do vertical grafting to cover this recession. You see that you are designing surgical papillas here, surgical papillas over there. What is the reason for the surgical papillas? If I design the tip of the surgical papilla to the anatomic papilla with 3 millimeters, it means when I suture this tip over here, the flap also advances 3 millimeters. So the distance from the surgical papilla to the recession is equivalent. Understand this? Nice. If your recession starts to be longer than 3 millimeters, I cannot do tunnel. If I do tunnel, the margin does not move up. So what we do? A trapezium. And the distance from this incision for the trapezium to the papilla is equivalent for the recession that you want to treat, right? So it's paramarginal incisions from Zuccheri combined for any flap design that you have, okay? Let's go, partial preparation, nice, releasing in the mucosa, nice, and then patient has not a good tuber. One of the options that we're going to use here is pedicle flap, okay? Pedicle flap has some huge advantage, but also some limitations. The big limitation of the pedicle flap is the quality of the connective tissue that you bring together and the thickness of this connective tissue. In tuber, we know that we have around 6 millimeters of able, and I can take it all. From palatal side of my patient, average is 4. So if I have a very good palate, 5, but I cannot take the 5. It's going to be just part of that, and usually the deep part that is the most fat and glandular content. So pedicle for vertical augmentation does not perform so well as the tuber. What is one of the advantages for pedicle? Pedicle is very good for me to use when I do bone augmentation and the buccal flap is destroyer. Remember that? I mentioned this in the first day because the pedicle survived itself. And there is one thing that the pedicle is amazing. Remember this because you're going to need to use that. Few cases we have vertical deficiency. Combined with low recessions. These vertical decisions combined with low recession, by any classification that exists nowadays, is not treatable. You cannot treat that. The best chance for us to have this tissue back here is the pedicle flap. But the pedicle flap, when you bring the pedicle flap is not here. Pedicle flap rotating, embracing this tissue here. Is the best shot that you can have to try to cover a case like this one. Otherwise, you know, people sometimes pull the tooth out, right? So this is a few things that the pedicle flap is really important. Thank you. Blade is sliding sideways. When you choose a palate, choose a very thick palate. And what was the other thing that I need to pay attention to do pedicle? The rugging. Don't get a very intense rugging. Sometimes the rugging is a big problem for us to do a good preparation. And you can have a small perforation. Sometimes what we can have to do. Checking the limit. Roof of the mouth, lateral wall. I'm not going to bring this blade deeper than this, otherwise I can cut the palatal artery. If you cut it, it's not a big problem. Usually you can manage that really nicely, right? So coronal, mesial, apical incision. Okay. Posterior for the pedicle flap, we let the stop. Why is that? Because the stop makes the flap not to collapse. But close to the recipient side, you do not need to have the stop. Why is that? The pedicle is going to rotate, make this space empty, but the pedicle is going to rotate and still fill this space. So there is no collapse of the window here. I do not need to maintain the stop in this margin, right? Nice. Let me just show one thing here for you guys. I think it's better for me to draw this over. This is a beautiful picture here. Can I have the lights up? Pedicle flap you can use for bone grafting, right? And for vertical augmentation. Any vertical augmentation that you're going to do the aesthetic zone, if possible, you're going to use tabletop. Okay? Tabletop is the way you prepare the recipient side. Does not matter if I'm going to place over the recipient side a tuber or a pedicle. Okay? So let's just design here a recipient side tabletop once more. Imagine that I'm in the proximal side. If I design a tooth here, you can imagine where the tooth belongs. Nice. Palatal tissue. In here. Nice. What we do? Incision in the center of the crest, remember? Incision bevel a little bit to the recipient side, bump in the periosteum, remove, and keep it parallel to the periosteum. When I get to the mucosa, incision to the surface. Muscles are here. And then my flap is beautiful release. Nice, everybody understand this? Okay, what I do with this piece of tissue here? Remove, detach, or just the epithelialization. The epithelialization. I'm going to remove the epithelium here between 3 to 6 millimeters. No epithelium anymore. Okay, I show you in the first day that I bring the tuber over here. Vertical graft, and the tuber is my first option because the tuber is strong, thicker, right, dense in collagen. But not all the time I have the tuber available. In a few cases, I have situations like this. I want to cover this as well. So pedicle flap is back in the game. I'm going to rotate the pedicle, and guess what? I'm not going to take this tissue out. I'm going to design the pedicle envelope from this margin palatal, and the pedicle is going to rotate over both. Is the pedicle that is going to cross here. Understand? And the flap is going to try to go over. Right? If I take this tissue to rotate the pedicle, I have no increments. If you want to build vertically a wall, one brick, second brick, third brick. If I get 3 bricks and I take the first one, fill 2 layers. So maintain the layers here for us to do, okay? I just position other picture here to show exactly the way we prepare the tabletop, but we're going to have other cases as well. This incision is very similar to the subepithelial incision that you have. Same window, parallel, everything else. They stop here, but I don't place any stop close to the area that I'm going to rotate. Can you see the incision from the tabletop starting here? So buccal, I have designed tabletop for this patient, right? Incision in the center of the crest, partial preparation, exactly as I mentioned here. And what happened with this tissue in the center, Ricardo? The top of the crest, what we're going to do? Deepithelialization. Oh, sorry. Remove the epithelium in the surroundings. Have better picture. Removing the epithelium on the surroundings, and I rotate the pedicle. My chance to vertical build something is over a solid base. Understand? We introduce 2 modifications in pedicle flap. One is to use the pedicle flap for treating the recessions, like a beef arrangement you're going to see. And the second modification that introducing the pedicle flap is associated the pedicle flap with the platform or tabletop technique. Let me just move back to my case here. We are preparing a small top or table here in my case. It's not so clear in the picture, sorry about that. Rotating a very nice pedicle, but you see the quality? Too fluffy, fat and glandular content, right? Deepitalization of the anatomic papilla, deepitalization of the anatomic papilla, because I'm going to advance this flap over there. And here we are splitting the pedicle into tongues, right? Like a bifid, like the viper. One tongue embracing here, one tongue embracing there. Why? For me, it's priority to try to lift this tissue and to lift this tissue that is the base of the papilla and the recession, and to have a lot of tissue here. This tissue later can solve with a proflap. You can have the papillas. But papillas is very hard for us to have, right? So I need to focus all the tissue that I have over there. One suture mesial, one suture distal, and then I close the flap. Nice. After a few days, patient was using a removable. Removable is good because if the patient has a small necrosis, the removable is basically a stent for the patient, right? This is, I think, 7-10 days later. Nice. And this is already with 60 days or something like that for the patient. So a good recovery of a deficient site. Currently, in case like this one, we do one more graft. Right? If it was tuber, maybe we have solved this case once. But it's a pedicle flap. Sometimes patient, I need one more graft. And look here, recessions covered. Right? This was the bonus for the patient to cover the recessions over there. Nice. Little bit more pedicle and table. Let's go. This, I have a few friends. They are not the dentists. Because a guy that sent this to you is not your friend, right? They're like, Ricardo, can you solve this? Really? Now? Okay, yes. Your case, guys, okay? Can you try to lift this papilla? No. Cannot lift this papilla. Too narrow. At least with this abutment here, impossible job, okay? So what you're going to do? Remove is lift the implant, okay? Let me just tell you one thing here. When you slip the implant, you need to be careful about the size or the height of the hidden abutment that you're going to use or the cover screw. Why is that? If you use a cover screw, of course, it's going to be in the level of the implant, right? And then you graft the case here. For you to find this implant once more, that is difficult. So you can use a small hidden abutment sometimes to make it easier. But the hidden abutment needs to be below the level of the gingiva by the point when you slip for that to be below the level. Okay? So choose wisely the level of the hidden abutment, the size of the hidden abutment about that. What you're going to do here, Ricardo? First, let's pray. Okay? Then do the surgery. So, but incision in the center. Partial preparation. Get into the mucogingival line. Superficial. Here. Full. Here. Full. Tabletop preparation. Okay? I told the patient that we're not going to solve this case. The patient does not want to extract the incisors and the canine. We're going to just diminish a little bit this deficiency. He's a doctor, anesthesiologist, young patient, 32, 33 years old, and high smile line, and with this huge deficient side. Partial preparation, really releasing the flap, detaching the papillas, good thing. Okay, let's go back here. That is good stuff. Can I have the lights? You're going to earn a certificate, right? For the ones that answer properly this question. Sorry, it's a joke, okay? Black triangles. Papillas are wider than 3 millimeters, so it's doable. Okay, I can leave that. I know that I can bring tissue over that. My question here, you're going to choose tunnel or you're going to do core advanced flap? Recession 2 millimeters only. Tunnel. Why tunnel? Help me. Because I want to ask. We need to lift, right? Because this contour, 1, 2, 3 millimeters, 4, 5, okay, 6 millimeters. If I flap this case and not lift, you're going to bring these small papillas to the interproximal side. This flap not move only cornally. If it was only cornally, I can fix this flap here, no problem. I can have the release, but this flap goes to the palatal side. So basically, what you have here is a neck of a t-shirt. When you move the papillas toward to the lingual side, how is the neck of the t-shirt? You strangulate the tooth and you cannot move the tissue over there. That's why we choose tunnel. But if the recession was very long, look how is the neck of the t-shirt. I can move this papilla way palatal and no strangulation. Good, I can move a lot. Okay, understand this? Nice. When you do tabletop and you want to move this flap, you know that the tabletop, this flap is not corner. This flap move over the table at least 6 millimeters in a few cases. You're going to have a long area, and it's easier for you to get a tabletop covered by the flap when your patient has together a small recession. Understand? Because I have a long contour of the flap here for me to bring it up, move to the palatal side, is stretching this contour in the neck of the tooth. Understand? Yes? Otherwise, I'm going to need releasing. Understand this? Yes? No. So I need to make completely the tissue sides mobile, papilla elevator, nice, checking the releasing, nice, releasing is reasonable. Pedicle, nice. Why are you using pedicle here? This recession, I target this recession. By the book, no technique can treat this. And no technique can cover this recession here because there is no interproximal teeth. So my best alternative is the pedicle flap. Okay, nice. Let's go. So pedicle flap is being designed. And if the pedicle flap is together for soft tissue augmentation, what I'm going to do with the top of the crest? Tabletop or platform preparation. Understand this? Yes or not? Yes. Just for us to make difference between one thing and another. If this was bone augmentation, there is tabletop? No. Then you rotate the flap is straight because you want to very often to cover everything that you have. Understand the difference between one thing and another. So here, this incision goes as close to the margin as possible. You use the probe, nice. And the target is to get into the distal palatal margin of the incisor. Incision goes here, and you even split a little bit this area. Just don't split the nasopalatal canal. And angulated blade, oh, really good blade. This is the limit. Nice, respected the limit. And unfortunately, the quality of this graft was horrible. Fat and glandular content. This is a lottery sometimes, right? So rotating here, and remember, apical incision. You bring the apical incision here. If you want to have more mobility, don't bring this incision forward. You're going to bottleneck in the blood vessels. Remember this? So you bring the incision here. When you see that the width of the base of the pedicle is getting narrow, what I do, I get the blade and I push the blade in that direction. Be careful not to cut the flap. So the blade goes here all the time, wider contour. Then, I don't know what I'm doing here. Distal, apical, coronal. Nice. Getting the sulcus, rotate the pedicle. Beautiful pedicle, but the quality of the tissue was not good. Okay? If you suture the pedicle straight down, if it was a bone deficient site, of course, there's no tabletop, but you suture to cover the deficient. But you are targeting the recession. So what you do, you split the pedicle in two tones, okay? And of course, as I have no good tissue available, what I did, get one extra tuber, right? Then you can do, it's doable, right? Make the depthalization of the tuber. I just check in the arrangement. Ricardo, how get this sandwich? Now is the double Big Mac. You know, there is the Big Mac and the double Big Mac, right? So multiple bits inside the recipient side. That's cool. I will not to say much, but no pressure. The epithelialization, periosteum, palatal incision that separated the pedicle. The flap is going to be here. First, suture the tuber. Second, rotate the pedicle. Third one, the flap goes over. Okay? Double Big Mac technique. You can name that. It's funny that when people give a lot of name for the techniques, right? And so I'm going to need to do the deepthalization here on this area. Be careful to remove really the epithelium, careful. Now I cannot see this picture, but I want to show the separation from the epithelium really for the connective tissue. Here you can see that I removed the epithelium since from here. Why here you can? Because probably the pedicle is going to touch this area. It's better for you to do a little more deepthalization than less, so the tissue can attach it. Suturing for the tuber first. Okay, everything is stable here. Probably I have done a horizontal mattress and single interrupt sutures to fix that. Now I'm going to rotate the pedicle over, and one wing there, one wing over the other side. Fat and glandular content, not good, and then close the flap over this area. Nice. This is 4 weeks follow-up. Why this tissue does not create much keratinized attached gingiva? Because it's over fat and glandular content graft, right? So this is the vertical augmentation for a single approach here. It's outstanding, right? This is the final result, and have it. On the break, I need to pick up this picture. Okay, I have these pictures here, one of the presentation for the final part of the treatment for the patient. So far, okay? Good? Okay. I'm going to bring a few cases, then I'm going to back for tabletop from tuber later. So this patient came to me and she went for different dentists. Her complaint was the papilla. Nobody wanted to touch the case and then came to us. Okay. There is a difference in the color, there is recession, the volume is not so good, but if the patient wants to treat the papilla, is of course vertical augmentation, right? This is the deficient side. Now, remember that I told that the buccal facial position of the implant can interfere in your treatment, yes, and also how close to the surface the platform of the implant is. The previous case was conical connection. When I have the abutment in my way and I have narrow papilla, what I did with the abutment? Remove it and I slip the implant, right? External connection. If this platform is here very close, can I slip this implant? Probably very difficult. If I try to cover this, it's going to expose again, and the flap is not going to be thicker enough. So this platform being very close to the margin, I cannot do vertical augmentation. And I need to slip this implant. Why I need to slip this implant? Because the papillas are narrow. I cannot do any lift of this papilla here. I cannot do anything, right? First option of treatment here, regular option, would be take this implant out, maybe you fix a new implant deeper, and you can close this flap. Maybe a small connective tissue graft can work still, it's going to help. Wait and do tabletop. With tuber. Why with tuber? Because of the quality of the graft, okay? Patient came from another city to try to solve everything that was possible in one strike. So I'm going to remove this implant, I'm going to place a new implant, and I knew that was not the time for me to use the tuber, but I want to try to do something. And I'm going to do what? Pedicle flap, okay? Pedicle is self-vascularized, does not depend so much in this area to survive. So let's take this implant out, remove the implant, new implant in, little more palatal approach, deeper, and I choose a short healing abutment, right? Not short, healing abutment, right? Not the cobra screw, because it's going to be easier for me to find this once more. And close to the bone level enough for me to cover that, right? Nice. And once more, design the pedicle. I don't know if I showed this case for you guys. I showed this? No, right? Okay. Small stop, but here what I do, I let the tissue on the top. Right? I'm going to go over. Deepitalization here, deepitalization over there, engaging the distal margin of the central incisor once more. And that full thickness. Now it's different. The quality of this graft here is way better. Right? Rotate, nice long pedicle. I'm going to cut the pedicle in 2 wings to give the support for the papillas. And the suture is going to be lateral suture, distal suture, deepitalization first, sutures, and try to advance the flap over this marker. Nice. Provisional, and 7 days later, what you do with 7 days post-op, guys? Take a picture and post on Instagram. The tissue swell, good volume, wow, tissue go back again. Okay. Small necrosis, and 9 days later, almost there. Okay. For 1 millimeter, maybe 1.5 millimeters, I could have good papillas for the patient. So what we decide to do? Second graft. Okay, this is the beginning, 90 days. So if you want to do baby steps, right, to be more secure, do the tabletop and just re-enter the case after 60 to 90 days. Okay, patient came from other town, fly to Curitiba, and I try to speed up the treatment. This increases the risk. Okay? Partial preparation, this is basically tabletop preparation. Do you agree? Yes. So what is the sequence now? If it was tabletop, deepitalization, bring the tuber, and advance the flap over both. Okay? So we can vertical get this. As the patient was from the other state, I need to give back already the implant exposed. And if I need to expose the implant, this is the way that I can expose the implant. Look here, the blade under the mucosa, right? Back in the releasing, good releasing, getting a tuber. We started this incision in the mucosa. One incision going to the palatal side. When I get 2 millimeters to the second molar, you open a small collar around. Same incision to the other side, small collar around. And this incision, the palatal one is parallel to the palatal tissue. The buccal one parallel to the buccal tissue. Nice. 12 blade. Nice. Raising the tuber. You see that here the tuber seems narrow, right? But as the incision is divergent, you see how wide is the base of this tuber. Small tuber, but it's still nice for me to use. And I'm going to have primary close here on the incisions of the tuber. If you need to graft the case and re-enter the case or place the implant, what we do, the incision is buccal palatal. Don't do incision this way, can you compromise the enlargement? Incision that is buccal palatal. Okay, nice. And expose the implant, take it out. If I need to use a healing abutment here, what I do with the healing abutment, get a very large healing abutment, then you kill the case. Get the small one, and still reduce more. A guy that does a lot of this treatment is Gamborena. Okay? For me, one of the most inspiration that I have for trying to challenge my limits was Iñaki Gamborena, because it's amazing. I saw a few cases of him a few years back. He showed that it was possible to build more tissue than I was thinking that was possible. So we tried to find a solution for us to do that. Unfortunately, when I bought his book, have you bought the book, Evolution? Yeah, it's a big book, full of pages, absolutely nothing related to the surgical techniques over there. It's amazing. I start to see, wow, beautiful. Surgery is going to be very soon. Where is the surgery? It's running out of pages. No surgery on that. So, okay, but he used a lot of narrow buttons exactly for this purpose. Okay? Lay down the tuber, advance the flap over. If I need to do the suture, first option, periosteum. Ricardo, I cannot engage the periosteum. Second option, mattress. Cross it, in and out. Alright? And if I need it sometimes, we place resorbable suture here, resorbable suture there, or even from outside, stretching the borders. Fine? And then close the flap. Nice, and the case is exposed. 10 days post-op, good tissue. 2 months post-op, good tissue for the patient to have the contour and the papillas over there. Okay? Nice? Okay, good. Yes. Let's go for vertical augmentation now. High smile line. Patient lived with this implant for many years. And I look the case. I promised the patient to reduce in half this exposition. The patient was already happy with that. We tried to manage the expectation of the patient. The problem that we post on Instagram, and the patient came already, I want this case for me. Not possible. No, you like my case. Okay, guys, you see, implants is integrated. Okay? Moving out to the crowns. Maintain or take it out of these crowns. Remember, the tight pants is doable. Yeah, but the pants is too tight. You cannot be walking nicely. This implant was 2 millimeters back here. Maybe you can do something because the space in the papilla was larger. You're going to see cases like this one in the sequence, but this implant is too facial. Don't forget this was the first thing we started to say about treating compromised implant. And for me, the buccal position of the implant is the thing that most affected what I do. Second thing is the space. Validate the space. It is narrow and you cannot open anymore, take the implant out. Anything that gets in your way, don't try to fight against the physiology of the body. Okay? So let's remove. Let's go. Take it out of the implants. Nice. Using the retrieval. Nice. 2 implants out. And I'm not going to do anything here, right? I'm going to let the tissue to heal, close these holes, and I'm going to do the graft of this vertical graft later, right? It is a very good deficient site, especially if I look at the level of the papilla that I need to emulate is here. So it's a long distance for me to build up over there. Which is the technique? Tabletop. Okay, let's see a video from the tabletop. Incision in the center, slowly touching the bone. I have detached, first of all, small full thickness here, and this small full thickness here, but this is a very comfortable, thick phenotype in the tooth. After the full thickness, partial thickness here, incision in the mucosa. Between the muscles and mucosa, right? Superficial. And you see that every strike of the blade, the tissue starts to be more free to move cornerly. And do this. Pull the tissue. Check. You can feel where is the fibers is still stuck. And don't forget to go as distal as possible, as medial as possible, because the tissue is going to be holding or stuck here, or it's going to be holding stuck here, or any place apical. Apical, you have done already a good job. So here I make this tissue to be mobile. Let me explain one thing. When we remove the implants from the patient does not want to have implants anymore. And we can solve with a bridge and pump it. For me, it's a very good solution for the patient, right? And I thought that I could solve this case only with soft tissue grafting. That's why I have no bone grafting. Okay, stop. So here, I was waiting like this. Is a projection, okay, from a recorder camera that probably is not 4K. Can you see still the epithelial line and the connective tissue line? You can see that. In the mouth, if you start to pay attention, you can see this. And this is exactly the area that we remove the epithelium. Sometimes it's thicker, sometimes it's thin. Go apical to this line here to be sure that you are removing the epithelium layer. And I go exactly in the line. Here, half a millimeter, Ricardo, more. Yeah, half a millimeter, sometimes we miss. It's difficult. A real blade now to really detach the mucosa from the muscles. You see that the blade is really in the surface of the muscles. Nice tuber, 12 blade, I think I showed this case when I showed the tuber. Yes, it was exactly this one. As I need a big graft, I was a little more greedy. I harvest the contour of the second molar as well. But I want to design a collar or a flap that still is going to accommodate the margin in the cement and arm junction. Measure how deep can I go, not going to penetrate much more than that. Day after tomorrow, I have 6 hours lecturing in Indonesia. And they want to have advanced cases. Then they keep me asking how I'm going to talk about advanced case in 6 hours and make people really understand what is going on, right? Sometimes it's better for you to cover the bases. Apical incision, nice, same thing facially. Then detach full thickness and remove it all. Sometimes when the patient came with this big deficiency, I pray for them not to have a second molar. Then to revive it. Guys, any doubt that you are having during the case's presentation, don't let for later. Later, we're not here. Okay? And tomorrow is going to be difficult for you to do the questions. So please do during the presentation. We stop and do the answers. I'm taking longer to detach the tuber because I make a mistake in the apical cut, if you remember from yesterday. Be careful to cut from inside to outside, of course. So I cut a few fibers, then I move to outside. Primary close. And remember one thing, tuber is Tetris game. You need to fit the piece properly to the recipient side. Not all the time, the shape that you get in the tuber is exactly the shape from the recipient side. So you need to trim, you need to cut, you need to adapt. And after you trim the graft, what you need to do? Fit in place. The graft needs to be there alone. If you need to push the graft to stay because the room is not wide enough. And then try to cover. Check if the flap can cover the graft. If cannot cover, you need to release again. And all the time check with the spatula. Absolutely no fibers interposed. Nice. Lateral sutures. I was not able to get the periosteum apical. My first suture is the comprehensive suture. I could not have done, I did not did this for this. So I'm going to do to the alternative suture. What is the alternative suture? A vertical mattress inside the graft. Vertical mattress is good, but does not stabilize the whole graft. And after the horizontal mattress, I'm adapting the corners, no gap, stabilization. After this, advance the flap. Look how the tissue is stable. I'm bumping the tissue, no mobility. One horizontal mattress there, single interrupted, graft completely stable. Beautiful. Let's bring the flap over. One horizontal mattress, a second horizontal mattress, and then single interrupted bites. The normal, it's going to be single interrupt surgery. The normal order of building tissue is bone, soft tissue. You just invert that if the soft tissue is really bad, then you create more soft tissue. But if you do bone first and soft tissue later, it's going to be easier for you to do the techniques, right? Because you're not talking here about this small soft tissue augmentation. You're talking about big soft tissue augmentation. I know that some old books, they say, if you're going to do bone graft and the tissue is thin, do a soft tissue graft before. Yes, but that is not big soft tissue graft. This is big soft tissue graft, okay? And then after a few months of recovery, the patient, 10 days post-op, what they do? Instagram picture. Yes. Go on site, and this is 3 months later, something like that, okay? Almost there, but still not there, right? Because I have a big bone deficiency. So, gladly, in this point, the patient decides, Ricardo, you know, when first surgery was not so bad, what do you think about implants? Say, okay, let's do the implant. And together with the implant, let's do the vertical bone building, okay? The problem is how to approach this tissue here, right? If you want to know if the technique works or not, that's it, okay? Palatal tissue does not move, and the problem is what to do with this tissue now, okay? We need to cut this tissue and throw it away now. Good tip, okay? Probably you do this, but for a long time already, if I need to collect the bone, I don't use irrigation in the drills, right? But the drill needs to be new or quite new, and the rotation of the drill is not continuous. You push, stop, push, stop, push, stop. If you do continuous rotation, even in slow rotation, you overheat that, okay? The storage of this bone here is 100% vital bone, no burning bone, but it's stop, push, stop, push. And you can collect amazing amount of bone. It's amazing, right? What else? So 2 implants there. I use the healing as stents to support my sausage. It was today, was quarry, right? And I'm using my piezo, or sometimes scrapers, to collect more bone around, spicula nasal, palatal tissue. I go palatal sometimes, I scrape tissue as well. And this small amount of bone is going to help me to do the 50-50 mix, right? Everybody talk about 50-50, but at the end you use as much autologous bone as you have, and then you complement with xenograft, right? So perforations in the cortical, nice. Using the sausage here, I like to hold the membrane palatal with a screw, not with tacks, because in my hands I don't work well in the palatal side. In buccal, nice, but palatal, I'm a disaster. Okay. If you want to use a screw for the collagen membrane, use the perforator for rubber ducks. Okay, you go there and do the perforation. Otherwise, the screw will start to rotate the membrane together. Nice. So here I can bring the screw, I can control, and I can position pretty well. No hammer. I feel more comfortable doing that. Okay. Nice. So membrane is stabilized to the palatal side, and I'm going to feel inside the space. It was close to 50-50, I think, the mixture. then close. And here I can use tacks, that is easy, or I can use screws as well. And the question or the problem is, what I'm going to do is this guy here, because cannot really close properly the flap, okay? So what we do, let me get here, you see, cannot adapt. So we're going to split it, yeah, like unfold it, right? So from inside I get the ungulated blade, and I start to split to bring this volume to the lingual side. Don't get excited doing this, that means you can perforate the flap.
Okay, question please.
Oh.
For this case, you do the soft tissue grafting first because the patient didn't want to.
And I thought I was able to solve with that. That is the problem for big omentis. Otherwise, the regular margin is there. Let me tell you something. I don't like to mess up much with the palatal tissue. Usually palatal tissue here I like to detach. I don't like to try to release. For my opinion, release tissue palatal is not doable, because you cannot repeat without have a lot of failure, right? The first guy that described a technique that you can release the palatal tissue was Tinti in the 70s, 80s, right? And until once in a while someone talk about the technique, also Zur island technique or something like that, man, difficult as hell, and the chance for you to compromise your case is huge. Right? Palatal tissue to release and to cover until nowadays I still don't feel comfortable masking this tissue out. Okay? Nice. Remember, thick tissue cannot be so mobile. Suture is to close things and to stabilize things. I need to promote stability. So this big tissue here for me to promote stabilization was not going to be against the flap buckle that is completely loose. Both flaps are mobile, nobody help each other. So where I go, I bite the border of the graft here, or the flap, and I go to the periosteum. Do the same thing there. This is now completely static, immobile. Now I do the sutures, right? And one thing, or good thing, that I have 2 layers of tissue to protect my xenograft. And I'm going to close that with horizontal mattress, nice and single interroot suture. Beautiful. Immediate post-op, 10 days post-op, stop. Nice. So this is 3 months x-rays. Now 3 months x-rays. What do you think? Good? Good enough? Yeah? Not what the dentist that referred the case to me thought. Ricardo, let's do a papilla analysis. If someone call you to do a papilla analysis, don't go. Okay? Papilla analysis. Who does papilla analysis? Ricardo, the central incisor papilla is not perfect, but central incisor is not a problem because it has no pair. If it's small difference, nobody compare. Canine papilla, it's nice, the same level to the canine. But the lateral incisor papilla, you still need to build something else. Then they told the guy, man, if there is one unique papilla that the patient has very nicely, is this one. I have a plan. Let's kill this papilla. Same level. Problem solved. Okay, so re-entry. When you enter those cases, if you have everything here, what you do? Punch, punch, okay? Probably today I have punch, punch, and I have tunneling in between the twin punch. I thought I saw a case like this one. A few years back, what you figure out? Palachi approach, or palachi, right? Don't mess up with the papillas that are okay. If you're going to do a palachi or palachi approach, incision can be done facial to the hidden abutment. Why is the reason? Because on the top of the hidden abutment, I can design the palate, okay, to lift this papilla here. And if you're going to design one wing, thinking in the blood vessels, don't invert, blood vessels rotate over there, okay? Deepitalization, why deepitalization? You're going to see, because I want to bring the flap over this guy to try to compensate. And why, okay, first, stabilize the tissue. How are we going to stabilize? Suture, getting the periosteum here, in the base of this palate wing, or the palate, how can I say, papilla. One more connective tissue graft. Then you close the flap, and you are close for having a decent papilla for the patient here. They never promise anymore to build up papillas. That is the message. Nice, any question? Good? No? Let me, guys, vertical rebuilding. You can still talk about that. Tabletop. One more case of tabletop, then I can move for different things. You're going to talk about tunneling papillas, okay? And anything that you may want to see. This woman belongs to a family of dentists and technicians. They are very famous in my town. The guys that visit Curitiba may have heard about Calgaro Lab. He's one of the very nice, one guy, Will Calgaro is one of the most, in my opinion, best technician in the world. And work for, how is the name of the dentist famous in New York? APA. He runs the lab over there, and I can tell that probably the level, the work in the clinic is very nice because he's a technician, but understands a lot about practice, protocols, and a lot of things. One of the families is this woman, and having all the family involved with dentistry, they never touch the case because they know it's going to be a problem, right? So here was a removable that she used for many years until we try to really do something. Outstanding palatal. The thickness of the palate here is amazing. Reasonable bone fix, right? Vertical deficient site. Nice. Nasopalatal canal, small one. You can dive over the inside. And once again, bone augmentation, nice. Scraping, autologous bone, mixing, nice. Palatal fixation, cover, suture stabilize the membrane, nice. Lateral suture, then close the flap. This is bone augmentation. And okay, good tip. How you close flaps for bone augmentation? Horizontal mattress, right? Thin phenotype, you do the horizontal mattress, and the horizontal mattress do this thing with the flaps. Thin tissues move up, and then you have more area for them to encounter. Less chance for having exposition. But if your tissue is thick, not a thin tissue, you can do one modification for your horizontal mattress. If the tissue is thick, you're not going to have this action, right? And you can modify the suture for Laurel modification. How is the Laurel modification? You're going to build a horizontal mattress. You see, it's ready for me to tighten the knot. But before tighten the knot, bring the needle here and pass under the palatal loop. So we're going to bring the palatal loop over the tissue. So I have one layer down, one layer up. The Laurel modification do not allow the tissue to do this movement. So don't do Laurel modification if you want to have this, if the tissue is thin. But if the tissue is thick, the Laurel modification basically close the flap. You're almost not going to even need, but you're going to do anyway, single interloop sutures here to close that. 2 Laurels, then single interloop suture. I don't know here why I let this papilla open. I'm going to pay the price for that in the end. Nice. Augmentation. Nice. 7 days post-op. Good. good. Bone augmented, it's okay. And I need still a papilla. Everything was good, but there's no papilla. So now, tabletop. Thickness, releasing. I have no good tuber. Let's go for the good palate. They stop here. Small releasing, not all the way down, half away from the size that you want to collect. You don't need to do a big releasing, and outstanding palate, right? Sometimes, not every time you are bad luck. With this top, I can even use interrupt suture here. But if you want to do compressive suture, go as apical as possible for the suture to close. But with this top, whatever you want to do, you're going to be fine, okay? Try the graft in, nice. And if you have a more fat content, push this to the no-nubble area. That's the dense part to the top, all right? Nice. Suture that first, and you see how much we advance this graft over the palatal tissue, and you need to make the fat to go there. So I have the 3 layers that I want to have. I don't know what happened. I think this is deficient from the first surgery yet, and I didn't see this. I don't know. Right? 10 days, Instagram. In a few days you are famous. 90 days pause-off. I was not really so concerned because I have the bone peak here. I knew that if I just conditioning this, the papilla is going to be here. But that scared me in the first sight, right? And if the tissue is there, and I think the tissue is okay, I'm going to just punch the tissue, guide surgery, and remember, if you build up a lot of tissue, the sleeves is going to be inside the gingiva. Remember? So what I need to do, plant the implant 3 millimeters out. The sleeve is going to be in the margin of the gingiva. So the sleeve is here, the implant is going to be 3 millimeters outside the bone. No, I'm going to use a drill 3 millimeters longer to compensate this strip, right? So they did 3D planning, facial scanning, all the final rehabilitation of the patient to generate the guide and the proper position of the implants for me. It was not my job this. They did in the lab, and I have the guide back here. So, guide surgery. This new dent facilitate a lot or simplify a lot the guide surgery with the easy guide. It's really stupid to the point that it means simple. Any guide can do this, follow the line, right? And really there is not really much to think about. Strong is doing the same thing with their system. They are simplifying the steps that we have, right? So punch, take the punch out. I have 7-8 millimeters one, and 7-8 millimeters in the other, right? Implants is going to be there. Sequence of the punch. Remember, one thing that I need to do the punch, what it is? Pressure the punch. The punch really needs to be compressed against the tissue for you to take the punch there without any interference. Right? There's also the sequence of the drilling. Nice. And the real thing is when you take out the drill and have bloody bone, right? Not particles. When you drill and bring just white particles, oh my God, something is wrong here. And this is just demonstrating that the guides are planned to the sleeve to be with 6 millimeters from the implant position. So I want to use longer drill to compensate that, right? Implant is going to be there. Nice, 2 implants. And remember, implant for the guide, the implant is going to be 3 millimeters outside the bone. Then I'm going to take out the guide, and I need to finish by hand. These 3 millimeters that you need to finish by hand, sometimes the implant gets with a small inclination or misposition. Nice. This is 7 days follow-up, and this is the provisional when I send back the case for the family to restore the case here with small appointments what's necessary for the conditioning stage. Okay? Good. Guys, let's do 1 or 2 questions. Then you're going to do a very short break, not the 30 minutes short break, right? 15 minutes is going to be okay, so no problem about that. Any question? You want to have coffee, right? Okay, 15 minutes break, guys. See you soon.
Lúc đầu đó ông đang nói